Hello, welcome to Personalizing Treatments for Patients with Non-Small Cell Lung Cancer, presented by Albert Einstein College of Medicine of Yeshiva University at OMed Live. You are tuned into today's first session titled Advancing Personalized Care for Patients with Non-Small Cell Lung Cancer, Tumor Genotyping and Biomarkers. My name is Dr. Jyoti Patel, and I'm an Associate Professor of Medicine at Northwestern University Feinberg School of Medicine. I'm pleased to serve as chair for this important educational program. Today's session is a live and interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I now would like to introduce our first faculty member, Dr. Ajit S. Paintal, Assistant Professor of Pathology at Northwestern University Feinberg School of Medicine. Ajit, thank you so much for joining us today. I'll now hand the program over to you to begin our discussion. Thank you.
Thanks, Dr. Patel, for that kind introduction. And my name is Ajit Paintal, and I'm an Assistant Professor of Pathology at Northwestern University in Chicago. And so, again, our topic today is biomarker testing in non-small cell lung carcinoma. And so, obviously, non-small cell lung carcinoma is a very common disease. It's something that we deal with on a weekly, or if not a daily basis, as both oncologists and pathologists. But even though this is a common disease that we're very familiar with, it's an area where the paradigm is rapidly evolving, and it's a place where the paradigm seems to shift year to year, if not month to month. So I think it's a worthy topic for discussion. And so for today, I'd like to focus on the rationale and practical considerations behind biomarker testing, and maybe mention a bit about future directions as well. So just to sort of frame the issue before we go any further, as far as the pathologic diagnosis of non-small cell lung carcinoma goes, really in the last 10 years, even since I've been in training, the paradigm again has shifted completely almost. So 10 years ago in 2004, once you establish a diagnosis of malignancy, all your job as a pathologist really entailed was making the distinction between small cell and non-small cell lung carcinoma. And that's not to say that we couldn't distinguish an adenocarcinoma from a squamous cell carcinoma. We could and often would make this distinction, but it was just not really relevant for purposes of therapeutics and prognosis. And obviously now, 10 years later in 2014, this has shifted entirely. We're still responsible for distinguishing small cell from non-small cell lung carcinoma, but currently there's a huge premium placed on the accurate distinction between adenocarcinoma and squamous cell carcinoma, again, because the therapeutic paradigm has evolved. And in addition, our role as pathologists has evolved to incorporate triage of tissue for molecular testing, because again, molecular testing is now very important for dictating first-line management in patients with metastatic disease. And currently, molecular testing, as mandated by the NCCN guidelines, includes testing for EGFR and ALK, as we'll discuss, but it's entirely likely that in the near to midterm, the list of molecular targets that we're interested in and required to look for is going to grow. So this role as sort of being responsible for triage of tissue for molecular testing is a part of our job that's likely to only get bigger. So I think I'd like to approach this issue in maybe three distinct separate parts. First, we can discuss the biological and therapeutic rationale for biomarker testing. Next, we can briefly go over some of the molecular testing methodologies and platforms which are currently available both in academia and in more community-based settings. And finally, we can discuss some practical considerations for implementation of biomarker testing. It sounds very trivial to just start doing this biomarker testing in cases of non-small cell lung carcinoma, but really there are a lot of moving parts and a lot of players that have to sort of buy in: the oncologist, the pathologist, pulmonologist, and radiologist. And so it's not as easy as it might appear at first blush, and so we've learned some lessons along the way that hopefully we can share and that will help you in your practice. So moving forward now, I think we've recognized, even before we knew anything about the genetic basis of lung cancer or about the different molecular sort of pathways that are involved, we've recognized for decades that non-small cell lung carcinoma is a heterogeneous disease or even group of diseases. So even if you just look at them under the microscope, an adenocarcinoma and a squamous cell carcinoma are generally quite different from one another in most cases. And there are obviously differences in regards to the predilection for patients with smoking and their association with different sites of the lung. So we've recognized that there are some clinical pathologic differences between these tumors for a long time now. Again, non-small cell lung carcinoma is very heterogeneous. And as we've learned more about the molecular basis and genetic underpinnings of these tumors, what we've found is that there are different groups of non-small cell lung cancers which are clinical pathologically defined by the presence of various sort of initiating genetic events or driver mutations. And so these driver mutations, again, initiating genetic events, occur early in tumor genesis, so they're going to be present throughout the entire tumor and in any metastases that sort of develop. So the earliest one of these driver mutations that was described was KRAS mutations, which were, I think, recognized in a subset of lung cancers as far back as the 1980s. And more recently, and maybe more relevance, we've found EGFR mutations and ALK rearrangements in a number of lung cancers as well, in addition to a number of other driver mutations. Again, we're mostly concerned with EGFR and ALK because those are lesions for which there exist FDA-approved targeted therapies. But again, it's likely that there are more targets of interest that will sort of arise in the near to midterm, at least in the FDA-approved sort of context. And so the chart I just showed you is for adenocarcinomas. As we learn more about squamous cell carcinomas of the lung, what we're also finding is that there are a distinct group of driver mutations that are present in many cases of squamous cell carcinoma as well. And so maybe of most note, FGFR1 has been described as being present in about 20% of lung squamous cell carcinomas. And again, there are others as well, and we're discovering more pretty much every year. One important thing to sort of note about these driver mutations in both adenocarcinoma and squamous cell carcinomas is that they tend to be mutually exclusive with one another. So for the most part, if you have one driver mutation, that pretty much precludes, for the most part, the presence of any other driver mutations. There are some exceptions in the literature, but by and large, these mutations tend to be mutually exclusive with one another. Okay, and so insofar as how this impacts therapy at the current time, again, biomarkers is sort of a buzzword that we like to use, but the driver mutations are biomarkers that we're sort of most interested in at the current time are EGFR mutations and ALK rearrangements, which are present in a subset of lung adenocarcinomas. And the reason that we're interested most in these two lesions is because there exist FDA-approved targeted therapies that you can use for patients whose tumors harbor these lesions. So for EGFR mutated tumors, we have erlotinib and more recently afatinib, and for ALK rearranged tumors, we have crizotinib, and again, more recently ceritinib, I think was FDA approved in the last few months. We sort of forget about histology as being a biomarker, but if you think about it, histology is still an actually even more important biomarker than it was 10 years ago, in the sense that it's predictive of response to therapy. So for example, pemetrexed and bevacizumab are drugs which are relatively indicated in glandular tumors or adenocarcinomas and contraindicated in squamous cell carcinomas for purposes of, or for reasons of efficacy in the case of pemetrexed and for reasons of toxicity in the case of bevacizumab. So histology is an important biomarker as well. And so again, just to sort of recap the role of pathology and how it's evolved, we're still responsible for a diagnosis of malignancy, just as we've always been. We're still responsible for providing staging information depending on the type of specimen that we received. But again, there's a huge premium now placed on the distinction of adenocarcinoma and squamous cell carcinoma because of the reasons we just discussed. And in addition, again, we're increasingly responsible for the triage of tissue for molecular testing. And the issue is sort of different than it is in other solid tumors because, as you know, in lung carcinoma, in general, most patients do not undergo resection. So that small little transthoracic core biopsy you get from radiology or the little tBNA that you get from a pulmonologist, that's the only material that is generally ever going to be obtained from the patient. And so we're asked to do more and more in terms of diagnosis and molecular testing on increasingly small amounts of tissue. So it's not a trivial task, triage of tissue for molecular testing. Okay. So moving on now to focus a bit on some of the molecular testing methodologies which are available. There are a few sort of ways to divide them up, but really the way which may make the most sense is to divide them up into single gene assays and multiplex assays. So single gene assays, you're obviously looking at a single target of interest, a single gene, ROS1, KRAS, EGFR, what have you. And depending on the nature of the lesion that you're looking for, in general, most of these tests tend to be PCR-based or based on FISH. In contrast, for multiplex assays, you can interrogate dozens, if not hundreds, of targets simultaneously. And they tend to use a somewhat different set of technologies. So one that's available is mass array technology, which incorporates mass spec and PCR, multiplex PCR, and sort of the modality that seems to be gaining the most traction currently is next-gen sequencing. And so multiplex assays tend to be mostly available at larger academic centers or at commercial labs on a send-out sort of a basis.